a high interest area across the region, and I think this will fit in very nicely and it's a follow-up to our last presentation there. Our speaker today is Dr. Erin Kiehna. Did I say that correctly?
Erin Kiehna.
Kiehna, okay. So I wasn't too far off. She's comes to us as the chairman of neurosurgery at Novant Healthcare and has a significant pediatric experience as well. She did a general surgery internship and neurosurgical training at the UVA, and then went on to a fellowship in pediatric neurosurgical sciences at the Hospital for Sick Children. I believe that's in Toronto, correct? Yeah, our former common medical director, Dr. David Jacobs, actually spent a year there at the Toronto Hospital for Sick Children, so excellent trauma experience there. So our topic today is on neurosurgical issues on the pediatric patient, and we look forward to your talk today. Thank you. I lost your slide.
Great. Can you see the slides?
Yes, now I can. Thank you.
Okay, perfect. So thank you guys very much for having me here today. As we all know, there's a lot of pediatric trauma in the larger Greater Charlotte market and region, and look forward to talking to you guys about non-accidental trauma in children, because these are the cases that I think are the ones that keep us up late at night. They wake us up early in the morning. This was my Saturday morning this past weekend. And they also, I think, are some of the most collaborative cases that we take care of. So wanted to kind of go over it, provide an overview for you guys, and do kind of two major case presentations. I also came from Children's LA, where I worked for 4 years before Charlotte, where we were probably the top level 1 trauma center in the region. So we've sadly had a lot of experience in this. I have no disclosures. So the non-accidental trauma is the leading cause of childhood traumatic injury and death in the United States. The incidence is only probably increasing if you look at the overall numbers going through the 2000s. It did hit a peak in about 2008, but it's come back down, but it's probably been going back up since the COVID era. We look forward to having more of these numbers released over time. It's very significant, with about 21.9 cases per 100,000 in children younger than 36 months, and 50 cases per 100,000 in children in their first year of life. Abusive head trauma accounts for about 80% of the childhood maltreatment deaths, making it the leading cause of death in this population. Abusive head trauma remains the most common death in children who are victims of NAT, and notably this usually occurs during the first year of life. The diagnosis is often missed because no history of head trauma is usually provided. Signs and symptoms that the child displays may be nonspecific, such as vomiting, poor feeding, irritability, or lethargy. When we go through the primary injuries that occur in these children, they can be epidural hemorrhages, subdural, subarachnoid, skull fractures, interventricular hemorrhages, cortical contusions, diffuse axonal injury, and intraparenchymal hematomas. So basically all the types of head trauma. The epidural hemorrhages, as shown here on the right, require a direct impact and are generally venous bleeds, which result from tears in the dural sinus or the diploic veins. Next, subdural hemorrhages may result from inertial shearing or rotational forces, but most commonly result from abrupt deceleration. So the head was moving in one direction and then stopped. Subdural hemorrhages are created by the traumatic separation of the arachnoid from the dura mater and are caused by bleeding from these bridging veins. You know this a lot from the adult population, where we see as our brains sadly start to get smaller as we get older, and then kind of minor bumps and falls can cause those bridging veins to shear. In children, this requires much greater forces. Infants may also be found to have hemispheric hypodensity, which we have colloquially called the big back brain, which is associated with subdurals and consists of a hypodense cortex and underlying white matter in multiple cerebrovascular territories. So the brain in these infants undergoes progressive atrophy rapidly during their hospital stay. It's been associated with increased intracranial pressure as well as high mortality. It's associated with secondary insults and ischemia, which I'll talk more about in a bit, and is common in infants with cardiac arrest, hypoxia, and hypotension. This was first described by Tina DeHame in Boston, probably about 20 to 30 years ago now, and this is an event that only occurs with non-accidental trauma. And if you look on the left, you can see how the cortex is much darker than the central brain. You sometimes see parenchymal bleeds in that. But when you go on MRI, they've actually stroked vast territories within the brain. And it's that injury that leads to a rapid decline in these children. So initially swelling, and then as the brain starts to dissolve, a rapid decline. As we move on, we can have subarachnoid hemorrhages from trauma. Usually the rupture of subarachnoid or peel vessels can occur, and you can see that blush like right here in the Sylvian fissure, or often on the cortical surfaces. Intraventricular hemorrhage can occur when subependymal veins are torn. Those are the ones that are lining the ventricles, and so they can spill a little blood into the ventricles. Cortical contusions involve the superficial cortical gray matter and tend to spare the subcortical white matter. Cortical contusions tend to involve the frontal and temporal areas. And as you can see on the slide, we often see them. We look just beneath that open fontanelle, right where the edges of the bone are. You see that drop of white blood. And so that is not that uncommon for us to see. Diffuse saxonal injury is another not uncommon event where sudden acceleration and deceleration forces combined with rotational forces can disrupt fiber tracts. Infants are much more susceptible to this because they have a very large head to body ratio, weak neck musculature, and thinner skull. And they don't really turn the corner on this until after about 12 months when their neck musculature is stronger. It typically affects the subcortical white matter, and we are looking for hemorrhages in the corpus callosum, the brainstem, and the internal capsule, as you can see in this image to the right. And finally, we can get intraparenchymal hematomas from shearing injuries, rupture of small intraparenchymal blood vessels, and typically occurs in the frontal temporal white matter, but can occur throughout the brain depending on the trauma. It's really interesting when you look at the accident pattern that we see with non-accidental trauma versus accidental trauma. So radiographic findings are vastly different. We all know that children suffer linear skull fractures. Whenever we see these in the ER, you tell parents this happens all day, every day around the world. So linear skull fractures are primarily accidental trauma and less common in non-accidental trauma. But you can see that the subdural hematomas are much greater in the non-accidental trauma population. Epidurals and intraparenchymal hemorrhages are equally low. Subarachnoid hemorrhages equally as rare in this population. Then when we look at how do we treat these, non-accidental trauma requires a different repertoire of surgeries than accidental trauma. We are performing craniotomies more often in accidental trauma. We're performing craniectomies where we have to leave off a portion of the skull, much more commonly in non-accidental trauma than accidental. Subdural taps, for example, what I did Saturday morning, that surgery is basically limited to non-accidental trauma patients. And then when we look at, we put intracranial pressure monitors in, we elevate fractures not uncommonly. But if you look overall, 92% of accidental trauma can be observed, but only 31% of non-accidental trauma. And that's a huge difference in how we end up having to treat these. And I want to show you guys a case presentation. So this is a 3-month-old X37-weeker who presented to the PCP with a 24-hour history of increased fussiness and vomiting. And the primary care doctor measured the head and saw that the head circumference was off the charts. And you can see this jump from the 6-week visit to the 2-month visit to the acute care visit. So massive jump in head circumference. When you looked at the baby, there was macrocephaly clearly. The fontanelle was full intense. And you can see that the eyes are what we would call sunsetting. She sent them immediately to our emergency room where the baby was bradycardic and hypertensive. And then a head CT was done stat, which showed the splayed parietal skull fractures. And then large bilateral subdural hematomas. And so when you look at the suture lines on this skull as well, you can see that these are wide open. But look at how wide open that skull fracture is. So that's not a linear non-displaced fracture that we see in accidental trauma. This one's had swelling and pressure beneath it. And when you look at this CT scan, this is a coronal, you can see that the brain is really pushed down inside the skull by these chronic fluid collections. So it does have more density to it than the cerebrospinal fluid that we see in the ventricles in the center, so we know that that is a chronic blood pattern. And so given that the child was bradycardic, hypertensive, and herniating truly, he was taken emergently to the operating room. And in those cases, we make small cuts on either side of the soft spot, the fontanelle, and we make a hole in the dura, the lining of the brain, and then we wash this fluid out. And we do that for 10, 20 minutes or so, washing liters of warm saline through that subdural space, trying to wash out all the blood. And most of the time when we open that looks like, I would say, Coca-Cola, iced tea, and we wash it until we can get it as clear as possible. And so the image on the left is the pre-op. The image in the middle is after surgery. The drains right there are coming out of the skin on the top, but they just feed into the subdural space. Then this is the MRI on follow-up, I think 2 weeks later, where we can see that the brain is coming up to the surface of the skull again. And then on follow-up, you can kind of see that the brain is filling that skull. And so that is how we often treat these kids in the acute care setting. But that's for the primary insult. The secondary injuries include diffuse cerebral swelling, herniation, infarction, infection, and chronic entities such as hydrocephalus or cerebrospinal fluid leak. So the diffuse cerebral swellings were usually seen in the first 24 to 48 hours following trauma, because children have a harder time auto-regulating perfusion of their brain. And there's probably also a larger inflammatory secondary response in children. You know, if you imagine an adult has a fixed skull, and they can regulate intracranial pressure with cerebral perfusion pressure, mean arterial pressure, all to a greater degree than an infant who has an open fontanelle. They can splay their sutures. And so it really leads to an impaired autoregulation, even though at the same time, by expanding their skull, they're trying to create more space for their brain. Pediatric patients also generally have a lower mean arterial pressure, which results in a greater likelihood for hypoperfusion and subsequent infarction. Subfalcine uncal or transtentorial herniation may occur if significant mass effects develops either from the primary injury or from the secondary injury of diffuse cerebral edema. And then hydrocephalus can be a secondary injury, which occurs when CSF absorption is impaired, either due to obstruction or impaired reabsorption. So if I go back a slide, I'll show you that while we drained the fluid spaces in the subdural space between the brain and the skull, the ventricles started to expand. And ultimately, this little guy got a subdural to peritoneal shunt, and then he ended up with a ventriculoperitoneal shunt for communicating hydrocephalus, because even after we had dealt with the subdural space, he still could not reabsorb CSF as well as he should. At the end of the day, you can see, though, that his head circumference has come down and is growing probably appropriately for his age. His brain is filling his skull, and we'd say all the fluid is in the right space and a balance between what you should have in your subdural space and you should have in your ventricular space. When we talk about trauma sequelae, it's not just the operative intervention that we provide. Our children require aggressive multidisciplinary care. Nearly 75% of children with non-accidental trauma have post-traumatic seizures, and nearly 20% of children with non-accidental trauma develop epilepsy. And epilepsy turns around and impacts that quality of life and neurodevelopmental outcomes. Of the survivors of non-accidental trauma, 30% have normal development. 20% have mild developmental delays, 20% have moderate developmental delays, and 20% have severe developmental delays. And most of the severe ones all have epilepsy. And I can't stress enough that this persists despite us setting them up with a comprehensive team of neurology, neurosurgery, in addition to their pediatrician, developmental behavioral pediatricians, and providing all the therapy services both at home for the young ones and at school for the older kids, neuropsychology teams. It's a huge team effort. And despite that, these children still have permanent sequelae of the injury. And so I wanted to move on from that, from like an overview of head trauma, to that of the non-accidental trauma and the spine. So of all these children with abusive head trauma, only 1% have spine or spinal cord injuries. And of all of pediatric spine or spinal cord injuries that happen, non-accidental trauma accounts for about 3 to 8%. So it is extremely rare in the big picture. But nevertheless, it's one of the most important things for us to recognize and to include on our survey of these patients. The pediatric spine is really unique in its structural and physiological features. I think from accidental injury, this is why we have rear-facing car seats till age 2 or till they outgrow them, because we know that they're at high risk for accidental trauma too. So the infant spine is more elastic than the adult spine because it's a largely ligamentous composition. So I joke with parents, I said, your child's more like a shark than they are like a skeleton when they're an infant. They have a lot more ligamentous laxity and relatively softer bone. So children are relatively resilient to fractures, but susceptible to ligamentous injury. And when the spine can have too much laxity to it, you end up with spinal cord trauma. Injuries restricted to structures within the spinal canal are thought to arise in hyperflexion or hyperextension when the increased flexibility of the column relative to the cord results in a functional shortening of the spinal cord. The pediatric spine is particularly vulnerable to injury due to the additional features of a horizontal orientation of the facet joints. So they're have kind of a rocker shape than the adult ones, or a slanted shape, and the underdevelopment of the intervertebral joints, and the relatively large size of the infant head, together with the low tone of the neck musculature. So the fulcrum of cervical flexion in an infant's high at C2-3, while it is relatively lower in the around C5 or 6 by about the age of 12. Sorry, 1 second. Sorry. The presentation of pediatric spinal cord injury is very different than we would see in older kids or adults. So 36% of infants present with respiratory distress and impaired level of consciousness, 56% with focal spine deformity and neurologic deficits, and remaining patients are questionably symptom-free. And I say that because it is very hard to detect. You can't do a full neurologic exam in an infant. When we ask about mechanisms of injury, 44% of infants have no reported injury. 36 are thought to have minor household injuries. That's what we're saying. The parent says, oh, they rolled off the bed, they rolled off the couch, those sorts of things. And 20% of infants have reported inflicted trauma. And oftentimes that's where one caregiver can describe an accident. Sadly, 56% of cases have a delay in diagnosis when it comes to the timing of them. And about 80% of children have associated abusive injuries, and the majority are other fractures. Of the outcomes, 31% have a severe neurological deficit, quadriplegia, paraplegia, and this is why it's so important that we identify these and try to limit the delay in diagnosis. 31% have some degree of neurological impairment, and 38% make a full recovery and are neuro intact, and I think that is a lot of credit to our rehabilitation teams. And the next question is like, well, where are these injuries occurring? Well, we talked about how the fulcrum of the cervical spinal axis is so much higher in children. And indeed, 48% of children with a spinal injury have cervical spinal cord injury, and it occurs at a median age of 5 months. 80% of the cervical spine injuries involve the vertebral column, and about 15% of them have spinal cord injuries. 20% were spinal cord injury alone, and vertebral artery injury occurs in less than 10% of cases, but nevertheless, that's very important to look for, because if you injure the vertebral artery, you can absolutely result in a stroke in the brain. The other common location is thoracic injuries. So that's 52% of children with a spinal injury, median age of 13.5 months. Overwhelming majority are fracture dislocations or compression fractures at the thoracolumbar junction. So that's T11 to L2. And 60% has spinal cord injury with signs of spinal cord compression, impingement, and injury. And so a lot of our knowledge comes from when we actually do get confessions at the end of the day. And these thoracic injuries are often children that are thrown across the room and hit the floor, hit the wall, and fracture at that T11 to L2 juncture. Wanted to go through an overall case of this because these are, like I said, extremely rare, but cannot stress how important it is to recognize these. This is an infant who was a full-term C-section delivery. At 1 month old, he went to the emergency room for decreased oral intake per the parents and was noted to have oropharyngeal trauma by the ER. The ER asked about the bloody mucus in his mouth, and the parents said, oh, well, he's been mucousy and we've been suctioning him, and it was thought to be due to aggressive suctioning, and he was sent home. He reappeared at the 3-month-old visit with severe failure to thrive in the emergency room. He was cachectic, weighed 7 pounds. It was his first visit to a doctor. That day he'd gone to his PCP, and it was his first visit to a doctor since delivery in 3 months. Poor hygiene was noted. He had multiple scabies lesions, horrific diaper rash. And the ER at the time was considering a metabolic workup because his parents had said that 13 months ago, an 18-month-old in their household had passed away of unknown reasons. While the ER was drawing labs and everything else, they did a chest and an abdominal x-ray, which showed multiple bilateral rib fractures in various stages of healing. And they got a head CT, which showed these biparietal skull fractures. And so this, at this point in time, on everybody's radar for non-accidental injury. However, the report for the rib fracture says consider metabolic causes, interestingly. When you see this child, this is, heartbreaking. He was cachectic with a weak cry. He could suck, but he couldn't keep a pacifier in his mouth. He was tachypnic with abdominal breathing, poor tone throughout, and scabies lesions around his body. You can see under his chin, neck there, and severe diaper rash. And, his skin was just kind of basically hanging on his body. So in a result of seeing this entire picture, seeing the head skull fractures, when I did the consult, I said, we really should get a brain MRI, part of a thorough workup and everything else. And from the brain MRI, we promptly ordered spine imaging because, as you can see, he actually has a burst fracture of the C5 vertebrae with severe impingement of the cervical spinal cord. If you look up in the brain stem on the spine MRI, you can actually see a small hemorrhage in the medulla right here. And then on subsequent CTA, we realized he had occluded a vertebral artery. And so all of these things going hand in hand accounted for what was originally thought to be low tone. But it turned out he's literally a C5 quadriplegia with an impaired diaphragmatic movement. Based on this, he went urgently to the operating room. And so in a child, there's no rules on how do you actually put a vertebral body back together. But this is with one of our ENT surgeons, Dr. Villeray, and myself. He did the tracheostomy, and I removed all the bony fragments from C5 and did a C4 to 6 fusion with fibular strut graft, and actually used our plates that we used to put the skull back together, because that was about the only thing that will fit in a small baby's neck. And so you can see this is actually an OR image taken on the operating room table. Sadly, it wouldn't let me show the movie where you can spin this around in 3D space. These are my retractors holding the skin open. And that's my fibular strut graft, the bright object right here in the center. And here you can see the fibular strut graft right here between the vertebral bodies above and below. And so he, as we said, he was C5 quadriplegia with loss of diaphragm, and that tracheostomy was very important because he wasn't controlling his own secretions as well. We did put him in a papoose board before surgery. After surgery, the only emergent solution you can provide after surgery is actually to cast him. So if you look here at the picture on the left, this is the soft cast from orthopedics cart to cast the chest, and we have to cast almost all the way down to the hips and babies, and casted it to the Aspen front piece in order to immobilize him. And then the bracing team came in, did 3D scans to start creating custom braces, which have to be changed out about every 6 to 8 weeks because the baby's growing as he is fed. You can see a feeding tube in place, and as he gains weight. And so we've moved through a series of custom braces on him over time, and actually just last week transitioned him from this custom brace down to an Aspen collar. We have repeatedly imaged him, and fortunately everything looks like it's holding stable on his construct. So he now has a rigid fixation throughout. So if we go back a slide, you can see that this is pre-op on the left here. And when you go to the right, you can see that my fibular strut graft, you can see his trach in place. And on the follow-up MRI, while there is some encephalomalacia in the cord, the remainder of the cord actually remains a good caliber. On exam, he is now, you can see he had all this tone from unopposed bicep strength. And his arms, that's slowly relaxing. You can see his arms coming down. He's actually going to be getting Botox to help relieve some of the unopposed muscle action and his more proximal muscles. And he's reaching with his arms for toys and his pacifier and those things now. The legs are still limited to, he does have some movement. He's very hypotonic. And so we're actually pursuing our rehab options for him now that he's 6 months old. So he went from 3 to 6 months. And he's still on the trach. They are talking about trying some trach trials, but I do think he's going to be somebody who ultimately will need a diaphragmatic pacer option or a nerve transfer in order to get his diaphragm to work again, but we remain optimistic. So these are, two representations of the non-accidental trauma that we receive in the neurosurgical world and kind of an overview, a little bit of what we do for these kids. And I really wanted to make this an interactive discussion, so kind of open up for questions and thoughts and everything else.
Outstanding. Thank you so much. Are there any questions in the audience? And I'll start off with one. We're often hesitant to do too much imaging, especially in children. What would be your recommendations, or what would you say is the most valuable thing for you to be able to see as the expert in neurosurgery?
Great question. So I think, I go by the PCARN criteria. Those have held up over time for what signs of trauma or what on clinical exam should warrant a head CT. What I would say, and actually on a kid that we had recently, most of our ERs have a sonocyte in them or an ultrasound. If you have a baby that comes in and that fontanelle's full and things don't seem right, while you're waiting for a scan, you can really easily put the ultrasound probe on the fontanelle, and that'll tell you the whole story in about 2 seconds. And so that happened recently, where I just said, "Where's your ultrasound?" And then definitely knew that child was getting a head CT and going, essentially straight to the operating room. For our practitioners that are working out of clinic and urgent care and stuff, one of the most important things you can look at is head circumference. In all of these children, you see that head circumference shoot up. It's one way that babies can protect themselves from increased intracranial pressure. If they have subdural collections taking up space or something else, they expand their skull. And nearly in every one of these cases, we'll see rapid growth in the head. And that's sometimes how we go back and try to figure out at what time things started to happen in these children. So as a neurosurgeon, we always say we want imaging, but I also always tell my, ER providers, I trust you guys. If you guys see something in the ER and you're going to get a scan, it's got good positive predictive value. You've got a full fontanelle, bradycardia, hypertension, seizing kid. Just go on and let our team know so that we can urgently intervene in these children.
Excellent. Any other questions from the audience?
Yeah, hang on a second. Dr. Torres has a question from the conference room.
Thank you for that presentation. Very enlightening. I was wondering, how long in that pediatric case does that baby need that Aspen collar for?
That is the $1 million question. There are no guidelines for how to reconstruct pediatric spine. When we discovered this on a Friday night, we knew we were going to the OR Saturday morning first thing. I reached out to a bunch of colleagues across the U.S. and they basically all said, good luck and let us know how it went and how you did it. It's as a result of that, there's a number of facts. So I used a cadaveric fibular strut graft as my spacer to replace the C5 vertebral body. But that piece of graft is much more, it's rigid bone compared to the soft bone that an infant has. And so I plated that in place to the levels above and below. So I really just changed the dynamics of the spine. The original, the collars, the casting, the braces and all that is to allow the bone to fuse around my screws. And to really, we want the vertebral body above and below to fuse together with that fibular strut graft. And so I would say for the first good 8 to 12 weeks, that's why we immobilize them. Now that he's down to the Aspen, and I said the Aspens for when he's upright and when he's in the car seat, which should be rear facing for life, and a couple other things. I'm just trying to keep him having a hyperflexion or hyperextension, which could somehow pull the screws out just because that segment's so rigid compared to the levels above and below it. I guess the bottom line is I think I told them to follow up in 6 to 8 weeks with new imaging, and then we'll make a final decision. But I know, I think a part of the problem as well is you've created a situation where he's been in a neck brace for forever that he also doesn't have the neck strength that he would have as a 6-month-old. So using the brace to try to give him some range of motion now, but still just keep one of those severe hyperextension, hyperflexion events from occurring. I hope that answers it.
It did. Thank you very much. A very complex answer. As follow-up to that, would you expect any type of take back or reconstruction as he grows older because of the fusion that's being made, or you expect the graft to grow with him and hopefully he doesn't need any other cervical interventions?
The short answer once again is we don't know. I honestly haven't found somebody else who's done a corpectomy and fusion in a baby. If he fuses around it, so if C4 and C6 fuse to C5, which it should because he's got a graft and a plate set up, he will become like a person with Klippel-Feil syndrome. And so that's where you could be born with vertebrae that fuse together. I think the biggest risk to him is when we might have to decompress him in the back at some point in time. And there's a very good chance he could need another fusion in the back. I don't think we would hopefully ever have to touch the front again. I think the other consideration is compared to an average human being, typically I feel like when you go through all of this as an infant, you're not going to end up 6 feet tall, is the long and the short of it, pun intended. So I think that'll put a little less stress on it as well. And somebody asked who's taking care of this child now. A bunch of us are. So he has a wonderful foster mom. She's actually up in the Winston-Salem region. So he follows up with a variety of us from Charlotte and in the Winston-Salem region. And she's actually trying to get him into a rehab program as well. And we are fully supportive of that. As we all know, it is hard to take a foster child across state lines and to kind of advocate sometimes for the care that you need. But he has a very wonderful, aggressive, medically savvy foster mom. So he is so fortunate to have found her. What other questions do you guys have?
I see several comments about thank you is a great case, difficult case. And you addressed the comment. And your contact information request. If you like, I can forward that on or put it in the chat box.
I think I can type it in this chat box. Novant, sorry, health.org. I think that should have just showed up in the chat box. That's my email. What else can I help with?
Any other questions from the audience? There's some great case presentations and with a difficult case, but with some incredible information. And Dr. Fraga said she would reach out to you directly with some ultrasound questions.
Yeah, I'm sorry I should have elaborated on that more, but it is I am a huge fan of ultrasound, both diagnostic, and then I actually use it in the operating room on most of my cases. It's a really useful tool in the modern era and provides us some of the best detail as well.
Excellent. Well, this is some, like I said, some incredible information, and we really appreciate and value your time. And you shared some very enlightening information. Any last chance for any other questions from the audience? Barring none, we really appreciate it, and I think we learned a lot from you. We appreciate it.
Thank you guys for having me.
Thank you. Have a good day.